Okay, so these two lectures, which is examination of the infant or child for dysmorphisms, are really lectures that, well, are sessions that were intended for the bedside. And when things or numbers of students got a bit large to accommodate that, we converted them to lectures. So the thing about this is that after we've been through these two, what I would really love for you to do is in your day-to-day interaction with children in various settings, on the wards, in clinics, in casualty, that you would practice what is taught here on the examination of the infant or child for dysmorphisms and later examination of the head. So we're going to start with a definition. So dysmorphism is a morphologic developmental abnormality. And that means that this is a finding that's present from birth. And the examination for dysmorphisms forms part of the general examination of the child, and particularly of the general aspects of the neurologic examination. When we're able to recognize a pattern of dysmorphic features, this often gives us a clue as to the presence of a congenital malformation, which may be due to either a genetic disorder or a teratogenic exposure. It's important to appreciate that the examination of the child for dysmorphisms is systematic, and a head-to-toe approach is highly recommended. Many times we recognize the presence of certain dysmorphic features and we sort of zone in on those and therefore fail to appreciate the presence of others. So it's encouraged that we approach this from a head-to-toe approach. The examination begins with general observations, looking at anthropometric features, the nutritional status, and examination of the skin. And so for each of these examples, hopefully I'll be able to show you a picture or slide to highlight the relevance. So when we look at anthropometry, that's important to look at height, because there are syndromes of short stature and there are syndromes of tall stature. So on the left are some pictures of a child with a short stature syndrome, which you guys should really read about. And this is the Russell-Silva syndrome. Remember that this is an interactive session, so I'm going to ask you to just describe to me some dysmorphic features that you see projected here. So, Danielle, do you want to start describing some of those dysmorphisms seen in the child with Russell-Silva syndrome as projected?
Hi, Doc. Morning. One of the features I think I noticed is it brachydactyly on the hands?
Okay, start with the head. What are you seeing there?
So, I want to say it's possible microcephaly.
Because it would be hard for you to comment on microcephaly from what we're showing here, because you're not seeing any reference points. Anybody else just wants to quickly jump in and speak about any dysmorphism seen in pictures A and B?
Morning, Doc. Does the child have low set ears?
Yes, there seem to be low set hair, but this is, yeah, go ahead. Anything else?
Morning, Doc. Is there frontal busing?
Right, Right. So I think that is what is intended to be shown here. So there's frontal bossing and
A broad forehead, like tapering to a narrow chin.
wonderful. Who said that? Daniel.
Yes, Doc.
Was that Daniel?
Yes, Doc.
Okay. Right. So there's frontal bossing, and this gives you the appearance of a triangular facies, right? So these are two dysmorphic features associated with this syndrome. And this picture at the hand is really meant to show some incurvature of the fifth digit or clinodactyly. All right. You're familiar with that term, clinodactyly?
No, doc.
Okay, I'm gonna type it in. We'll come to it again. Okay. And so Russell Silva is a short stature syndrome. The children are short. They have some dysmorphic features, including frontal bossing, a triangular facies, hemihypertrophy, so one side of the body is larger than the other, incurvature of the fifth digits or clinodactyly, and then they can have multiple caveolae macules. Their intelligence is normal. Saccharo syndrome is another short stature syndrome we'll see later, where these children are extremely small for age. They have associated microcephaly, a prominent beak-like nose. They're very irritable and hyperactive in their behavior, and they have severe intellectual disability. On the right, we have a tall stature syndrome, which we should all know about, and this is Marfan Syndrome. Can somebody just point out the features of Marfan that are displayed here? So keloid. Okay, Kabrina, go ahead.
One thing is that they have like very long fingers that they call like spider fingers.
Are you seeing that here?
The fingers do look long.
Yeah. What else you notice about her?
Um, the torso is also long.
Okay. I don't think not so much, well, the torso, but look at the length of the arms in relation. So she has very long limbs and long digits. And the long digits are called, what's the term we give for long digits?
Arachnodactyly.
Very good. All right, and we'll come back to Marfan syndrome. We know that this is a tall stature disorder, which is associated with things like hypermobile joints, scoliosis. They sometimes have an abnormal head shape called dolichocephaly, but importantly, they have lax ligaments, so they have laxness of the um, ligament that suspends the lens, and so they're prone to lens subluxation. They also have the predisposition to aortic root aneurysms, and they're also predisposed to congenital heart disease, mitral valve prolapse. All right. Okay, so this child on the right has Saccharo syndrome. She's she was 18 months at the time, and this was a sort of chubby 18-month who was in the clinic as well, so same age, and you can see the difference in size. You can see that, sorry, this is not Saccharo, this is Russell Silva. This child has a prominent forehead, and just to show you the disproportion or the difference in size. In terms of weight, we know that we have obesity syndromes, and these include Prader-Willi syndrome, a syndrome called Lorentz-Moon-Beadle syndrome, in which there is obesity, polydactyly, and mental retardation, and Cohen syndrome, which is associated with obesity, prominent incisors, hypogenitalism, and eye abnormalities. Prader-Willi syndrome is probably the more common obesity syndrome we will see. And these children start off being, often the diagnosis is not recognized until they become obese, but they start off being very floppy in the neonatal period. So they have neonatal hypotonia, difficulty swallowing, excessive drooling. After they get over that period, seem to be okay. And then towards the end of the first year of life, we notice that there is increased weight gain. These children eat excessively as well and will eat inorganic material, so they'll display pica. They have obesity associated with small hands and feet and underdeveloped genitalia. They also have a characteristic faces called with eyes that are said to be almond shaped. So these features characterize Prader-Willi syndrome, and they have intellectual disability. We'll come back to that again later. The skin is important because we're looking for features of neurocutaneous syndromes. So I'm just going to ask you to show me what features are shown here of neurofibromatosis type 1. Somebody?
The cafe au lait in this case.
Right. In the upper one, we're seeing cafe au lait macules and patches. And what is shown in the lower picture? Keloid?
Not. You mean the hyperpigmented spots or lesions?
Yeah. Yeah. In what distribution?
More.
In the inguinal region. So remember with NF1, they get these intertriginal freckling. So we can see it in the inguinal region and under the axilla as well. This is tuberous sclerosis on the right. Can somebody just describe to me the skin features that are being shown here?
So there are lesions on the face, beneath the eyes, and around the nasolabial fold, I guess, and the nose,
Right.
on the nose as well.
Okay. Do you know what these lesions are called?
Those are the ash leaves. Those are
No, those. These are called Angio Fibromas. Okay.
Okay, then.
And on the lower picture, what are you seeing there?
All right. So on the this looks like there are areas of hypopigmentation along the left flank of the patient.
And are these, remember, small lesions are macules, large lesions are patches. So these are hypopigmented patches, and these are the ash leaf spots.
Okay, then.
Good, thank you. All right, the head is also, so after you've done the general examination, then remember it's a head to toe approach, so we start with the head. But just to say that I'm going to leave the head out because that's the whole next lecture. Apart from looking at things like the hair, so the appearance of the hair can be a dysmorphic feature. So the hair might be thin or sparse or wiry, as we see here, or there may be a low hairline, as is seen here. So this thin, depigmented, wiry hair, this child has a syndrome called Menkes syndrome. So just to say that the hair is important to look at. And that's a problem with copper metabolism. These children have problems with copper metabolism. This other picture with the child with the low hairline, I want somebody else to just describe to me the many dysmorphic features that are displayed here. Okay, so I'm just going down the list. I'm not picking on anybody. So Jamaica.
Good morning, Doc.
Morning.
You want me to describe the one that has the pointer? You have the pointer on?
No, oh, no, sorry, no. Whatever dysmorphisms you see.
Okay, so I want to start with the picture on the right, which shows the body of the baby.
Mm-hmm.
So this is a baby or infant. So lying prone, and of note, the back of the baby or the entire body of the baby seems to have more hair than normal, I would think.
Yes.
And the arms and the back also have some folds.
Okay, so that hair, that's called excessive lanugo hair.
Okay.
And
And then
the skin folds, why I think those are present.
so it could be, well, I think it could be one of two things. It could be perhaps there's more skin than there should be, or it could be that the bone that they have is like it's very small. So then there would be.
Those are good thoughts, but it's actually due to loss of subcutaneous fat. All right.
Okay.
Okay, what other dysmorphisms you see?
I can't really see the face that well, but I feel like the the mouth is a bit low set and the chin as well.
Okay, so what we have here is that the hairline is
All right.
it's low.
Mm-hmm.
Okay, so extending onto the forehead and extending onto the neck.
Okay.
We can't really comment much on the eyes, but you do see a prominent nose. And this Philtrum here looks a little long, probably hard for you to recognize. But as you have said, the chin is receding, so there's retrognathia here. And then if you look at the ears, they look low set, and they're actually posteriorly rotated. We'll come back to all of that. All right, so this child has um, a dysmorphic syndrome called Cornelia de Lange syndrome. And we will meet other examples of that later on, where we'll see other features of the syndrome. All right, so we're at the hairline now and we're on to the face. We've spoken about the forehead already, which could be bust, sloping or receding, or maybe narrow, especially looking from above, associated with premature fusion of the metopic suture. So from above, it looks triangular, and that's called Trigonocephaly. Or the forehead may be broad. So we can appreciate the frontal busting here. We can appreciate the receding or sloping forehead hair. And there are other dysmorphisms to see. So again, a prominent nose, long philtrum, and low set the malformed ears. This is trisomy 13. Here we're seeing the prominent metopic suture with a triangular forehead. This is Trigonocephaly. And of interest, she has a wide nasal bridge with epicanthal folds, which gives us the impression that there's a strabismus. But there is not really a strabismus because when you look at the corneal light reflexes, they fall similarly in each eye. So this is actually a pseudostrabismus because of the presence of the epicanthal folds, which cover some of the sclera medially. So it gives you the impression that the eyes are turned inwards. Then we're down to the eyebrows. The eyebrows can be broad or narrow or diffuse. They can be tilted upwards or downwards, and they may meet in the midline. And the term for eyebrows that meet in the midline is synophris. So we can see here that there's synophris. Do you think there are any other dysmorphisms to see in this top picture? So we could
Doc,
go
would
to,
you say there is hypertelorism? No?
you're right, the eyes are
A little
wide
bit far
apart.
apart.
Anything else? So these are the palpable fissures. Anything you want to say about the palpable fissures?
Oh, it's it's narrow, the space.
They're narrow.
Yeah.
And they're down slanted, okay?
Okay.
So the outer, the lateral canthus is a bit lower than the inner canthus. And you can see that the nostrils are anteverted here. This is another picture of a child with Cornelia de Lange. This picture is a rare syndrome called Kabuki Syndrome. So on the lower left, and Kabuki Syndrome, Kabuki is a form of Japanese theater where the actors wear these, the faces are painted, and it, this sort of resembles it. So you have these eyebrows are tilted upwards, so like an inverted V. You have a very broad nasal bridge, and now you have hypertelorism for sure. They have eversion of the eyelids, which is not well seen here. Out-turned ears, long philtrum, and thin vermilion with a wide mouth. So that's Kabuki syndrome. And this picture is only put here to show you that there is the sparseness of these eyebrows, but this child also seems to have some ptosis and some periorbital fullness, small chin. Not sure what syndrome this child has. So we're at the eyes now, and the eye itself might be small, so that's microphthalmia. Looking from the side, if the eyes may be proptosed, or on the other hand, they might be deep set. And as we said, the palpable fissures may be up slanted or down slanted. So what are we seeing in this first picture that the pointer is hovering on for the eyes? So I want everybody to have an opportunity to contribute. So I'm going to ask Joanne, what do you think of the eyes in that first picture?
Hey guys. So one of the eyes are smaller than the other.
Right. So you think this is showing microphthalmia, right?
Yes, sir.
Okay. What about this picture to the right? Since your microphone is open, what is this showing?
Well, the eyes seem to be a bit large. So could that be macrophthalmia?
Well, they're large, but it's really just showing that they're deep set, you know, well below, well behind the supraorbital ridges. All right. So Travis, you had your microphone open, so you want to describe what you're seeing here? Okay, or Joseph?
Are those the upslanted eyes?
Yeah, not eyes, so palpable fissures.
Palpable fissures, sorry.
Do you recognize the syndrome, Joseph?
I'm thinking Kabuki Syndrome?
No, man, this is Down syndrome.
Oh, all
All
right.
right. And anybody else recognize this as Down syndrome?
Yes, Doc.
Right. I always make this point in the lectures that you haven't gone through each, you know, looking at her from head to toe, but it just jumps out at you. And that is how sometimes this morphology is, that you've seen the syndrome once, and when you see it again, it's easily recognized, like you get a gestalt for it. So this is, I find, an example of that. Just looking at her, you can see the upslanted palpable fissures, the wide nasal bridge, the epicanthal folds. You can't see much else, but it's Down syndrome. All right, how about this picture on the lower right where the pointer is? Is this Racine? I'm not sure if I'm pronouncing your name right. So you pronounce your name, Racine or Racine? Hello? All right. Having problems there. Sabrina, can you just describe what you see in this lower right picture?
Hi, Doc. The lower right picture, I'm seeing the eyes look. Are they? Are they down slanted?
What is down slanted?
The eyes, not actually the palpebral fissures.
Yes, I agree with you.
Right.
Right, so I don't want you all
sorry.
just keep saying the eyes are up slanted or down slanted. It's a palpebral fissures. This child also has the synophris, wide nasal bridge, anteverted nostrils, long upper lip or philtrum, thin vermilion, thin lips. Anybody recognizes this syndrome by now? Or wants to take a guess?
Is it Patos, though?
No, it's Cornelia Delange. So this is the third time we're meeting it in this presentation so far. So low hairline, synophris, down slanted palpebral fissures, thin vermilion, thin lips. Very good. So we're at the eyes still. And there are other things to note, like the presence of epicanthal folds, the interocular distance, which really should be measured. So this is just showing you how we should measure the interocular distance, and there are charts, reference charts to plot it. If it's too narrow, the term is hypotelorism, or if it's excessively wide, the term is hypertelorism. In the eyes, we also may see like a coloboma, say of the iris, which usually presents as a pupil that is not round, so sometimes like a teardrop or a keyhole defect. The presence of cataracts and cloudy corneas. So we can see from this picture on the left that they're epicanthal folds, and similar to the picture shown before, the epicanthal folds cover the sclera medially, And sometimes it gives the impression that the eyes are turned inwards. So you think that there's a bilateral esotropia. But it's important to look at the light reflex in the eyes, which fall about the center of the eye. And so you see that there is no esotropia, but it may be a pseudo-esotropia. Here we have a child with a prominent forehead, wide nasal bridge, large prominent eyes. And here we see a repaired cleft lip. Not sure what syndrome this is. In the middle, you can see that this pupil is keyhole in shape. So this is a collarbone of the iris. And then I'm going to ask Sawan to tell me what he thinks is going on in this lower right picture. Regarding the eyes. Okay, Simone.
It looks like a cataract in the left.
A cataract in the left. Okay. Everybody agrees, or could it be something else? What's a cataract, Sabrina?
It could be,
Go ahead, Simone.
I was saying it could be a leukocoria. So it's a cloudy.
Cloudy what?
Cornea. Cloudy cornea.
Yeah. So the cataract, remember the cataract will give you a white pupil. And a white pupil is leukocoria. So for anybody, if you're all at UHWI, there's a little baby we see on ward 14. And that baby has a white pupil. It's a premature exprem with retinopathy of prematurity. But this child actually has opacity, not confined to the pupil, but of the whole cornea. So this is a cloudy cornea. And is there more anybody can say about the eyes in this child, apart from there being a cloudy cornea? Anything else you can pick up?
Well, I'm not sure if it's the epicanthal fold or perhaps there's a squint or an esotropia.
Okay, just focus on the eye itself or the eyes.
In the left eye, there are two light reflexes, but I can't remember what it's called.
Well, and I don't think that's abnormal. Anything else about that left eye, Simone?
Is it larger than the right?
Right, it's larger than the right. So the eye is larger and the cornea is cloudy. What do you think this diagnosis might be? Simone, you were talking to me yesterday about toxoplasma. We might see this in some of the torch syndromes. So this is glaucoma, all right, congenital glaucoma. So you have an enlarged cornea or enlarged eye, cloudy cornea, okay, and this is congenital ophthalmos due to congenital glaucoma. Everybody recognizes that now? All right. So we spoke about the nose. We've been talking about a broad nasal bridge. We have a broad nasal root, a beak-like nose. So this is a child with Saccharo Syndrome. And here you can see that there's severe microcephaly, sloping forehead, wide nasal bridge. These palpebral fissures look a little upslanted, but prominent beak-like nose, micro retrognathia, and the ears look large because of the microcephaly. In this picture, can somebody just, this is probably not a child, but I thought it was interesting. What dysmorphisms are seen here, and what do you think this, what other features may be present, and what diagnosis you think this is?
There's heterochromia.
Right, so there's heterochromia of the irides, right? And we spoke about the broad nasal root and a bit of synophris. What other features you expect that this person may have, Simone? Or do you recognize the syndrome?
Is this the same Cornelia Deland?
So this is, in the interest of time, tell me if you have seen this syndrome before, Mordenberg. So you have a white forelock of hair, and there is deafness as well. Any of you have heard of that syndrome, Mordenberg Syndrome?
Yes, Doc.
Yes, Doc.
Right.
I think we saw it in clinic once.
Oh, you did? Wonderful.
Yeah, it was a baby.
Right, right. I think last year we had a baby, or it could have been 2 years now, born here with Mordenberg Syndrome, strong family history, and actually had associated, I think, Hirschsprungs, which can occur. So there are various types of Mordenberg Syndrome. Okay, how about this child here? I always ask this question, does she look dysmorphic to you? Like if you saw her, would you say she looks dysmorphic? Anybody? She doesn't strike me in particular of being quite dysmorphic, but she has a number of dysmorphisms. And she has the fetal alcohol syndrome. So what she has in keeping with that is a broad, flat nasal bridge, epicanthal folds, small down-slanting palpebral fissures. She has anteverted nares or an upturned nose, a long, smooth philtrum, and thin upper lip. All right. And children with fetal alcohol syndrome are likely to have intellectual disability as well. Thought this was a nice picture because to me it just demonstrates the subtlety of the physical findings of fetal alcohol syndrome, and it makes me wonder how many of them we miss. Although when we do take histories from mothers, Jamaican mothers, most don't admit to consuming alcohol in pregnancy. All right, so we've moved down from the hairline, from the hair to the hairline to the forehead to the eyes, the mid-face with the nasal bridge and so on. And now we're at we've spoken about the nose, the beak-like nose, the upturned nares and so on. And now we're at the lip. So this part of the lip is called the philtrum. And here we can see that the philtrum is smooth. A bit smooth here and long. And the pink part of the lips is called the vermilion. So here we have a thin vermilion. These are both examples of fetal alcohol syndrome. The lips could be thick, as seen here, with a wide mouth and some periorbital fullness. And this is a picture of a child with Williams syndrome. And of course, we may have, as we saw in a previous picture, a cleft of the lips. The mouth itself may be large, like this mouth as wide or small, or the angles of the mouth might be downturned. So the suffix for mouth is stomia. So if you have a small mouth, the term, I've never seen macrostomia, but the small mouth is called macrostomia. All right, so back to you for help. Can you just describe the dysmorphism seen in this lower right picture and tell me what syndrome you think this child may have? Anyone? Tanya, would you like to describe the dysmorphism seen here?
Good morning, Doc. Okay,
Good
so
morning.
I'm seeing the eyebrow seems to have some synopgels. I'm also seeing synopgel.
Do you say synophrys, right? P-H-R-Y-S, synophrys.
And there's also something there, pulporal folding. The
What you
nasal,
mean by that?
the palpebral fissures seem to be down slanting.
Okay, so down slanted palpebral fissures, and they look narrow too, right?
Yeah. They said to be a wide nasolabial fold as well.
I'm not seeing that, but how would you describe the nose?
It's upturned.
Upturned. How would you describe the lip?
The lip, it seems to be thin borders for the upper vermilion fold, and the distance between the philtrum seems to be long.
Long and smooth, right?
Yeah, and the ears seems downturned.
The ears, we can't comment much on the ears from this projection, but the hairline is low. So we've met this syndrome before. What syndrome is this?
What is this now? I'm not sure, Doc. It's not
That's the one.
fetal.
It's Cornelia de Lange. Remember, whenever you say the synophrys, downturned palpebral fissures, smooth philtrum, thin vermilion, that's Cornelia de Lange, all right?
Okay, Doc.
Not that it's so common, but we're just seeing a number of examples in this presentation. All right, so we're on to the mandible, and the suffix is gnathio. So a small mandible is micrognathio, and a posturally placed mandible with reference to the maxilla is retrognathio. So here we have some extreme examples of micro-retrognathio. Now, we've been talking about the ears a lot, and we use these terms low set and posterior rotation, but they have very clear definition, so we want to go through that. So to determine that an ear is low set, it means that the upper insertion of the ear falls below an imaginary line which passes through both inner canthi and is extended posteriorly. All right, so it doesn't say anything about what part of the earlobe is above that line. It doesn't say anything about a line from the angle of the eye to the occiput. It speaks about an imaginary line drawn through both inner canthi extended posteriorly, and if the upper insertion of the ear falls below that line, then it's low set. And you see the references for that. So I'm going to try to do this. So if this is this child's inner canthus, we can't see the other one, but we're going to take a horizontal line backwards, which I've done pretty good today, right? Then you can see that the insertion of the ear onto the scalp falls well below that line, so this ear is low set. If we did the same thing here, don't really like this picture because the head seems to be tilted backwards, but just for, you know, demonstration, if we took a line through both inner canthi and extended posteriorly, not a straight line, but it's obvious that this air falls below that line. The insertion of the air onto the scalp doesn't say anything about the earlobe. So that's how we define low set airs. Everybody is following that?
Yes, Doc.
Okay. Now, for posturally rotated airs, a little bit more technical. Sorry. I don't know what you're seeing and what all right. So for posturally rotated airs, what we have is, just trying to get my pointer. We have, and we take a line, which is called the Frankfurt plane. So it's a line from the inferior aspect of the orbit, and it extends posteriorly. So that horizontal line is the Frankfurt plane. We take a perpendicular to that line, and that's shown here. And then we look at the air, and you're taking what is called the medial longitudinal axis of the air, which is the two most remote points of the air. So you take a line through here and here. And if the angle that the medial longitudinal axis of the air makes with the perpendicular to the Frankfurt plane exceeds 2 standard deviations, or we just say 15 degrees, then the airs are considered posteriorly rotated. So I'm going to try that now. So we're going to draw the Frankfurt plane here. And pardon my not being straight, but that's the Frankfurt plane. If we take a perpendicular to the Frankfurt plane, so, all right. And then if we take the medial longitudinal, I'm going to undo that. All right, so we're going to draw that perpendicular again. Oh boy. All right, so we draw it. This is the medial longitudinal axis, so we're going to draw it here grossly. And then if we were to take a perpendicular to the Frankfurt plane, it would be here. If this angle exceeds 15 degrees, then that is a low set, not low set, posteriorly rotated airs. So it's a little complicated. All right. Other abnormalities of the airs include overfolding of the helix, preauricular pits or sinuses, and notches on the air lobes. So here we have a preauricular pit, that's a dysmorphic feature, overfolding of the helices here. And here we have a child with notching on the air lobes. She was large for age, had a bit of macroglossia, and this is an example of Beckwith-Wiedemann syndrome. Now we're just at the neck, which may be webbed. Can somebody just describe the dysmorphism seen here and tell me what syndrome you think this is? Any volunteers? Turners. Travis said Turners. And you're right. So what features you seeing here, Travis, in keeping with Turners? Quickly, guys. Travis, what features are you seeing here? Racine says wide space nipples, yes. Can somebody whose microphone works just speak quickly so we can move on? It's hard for me to read, watch a participant list, listen, pay attention. So I'm just going to ask somebody whose microphone is working to just describe the features, please.
Doc, I can try.
Go ahead, please.
All right. So, we're looking at the anterior chest wall of the patient. You're seeing what the neck appearance, the wide spaced nipples, and not really seeing much otherwise. But then on the posterior wall, I don't want to say, I want to say there's a kind of scoliosis. There's scoliosis present.
Yes, you can see that the scapula at different heights and there's an obvious curvature of the spine.
Yes.
Anteriorly, the chest is described as shield-like, so it's very flat, broad chest. So this is a shield-like chest. Okay, so here we have a child who has, the spine is pretty straight, but the scapula at different levels, and the scapula is fixed upwards here, and this is called a Sprengel deformity. And here we're looking again, and we're seeing the shield-like chest with the widely spaced nipples of Turner syndrome. Where at the abdomen, you may have an umbilical hernia, which is common in particularly in black babies, but this is a dysmorphic feature. Or there may be diastasis recti, or the presence of an omphalocele. The genitalia may be the labia majora may be underdeveloped. You may have the urethral opening of the penis on the undersurface or the dorsum, so hypo or epispadias. The penis could be small. There are various references according to age, or the testes could be undescended. Any pit, sinus, lump, or abnormal pigmentation along the spine is abnormal, and along the midline is abnormal. And of course, we saw the presence of scoliosis. As we said, the suffix for digits is dactyly. And so when we look at the hands, there are many abnormalities we may see. So here we have clinodactyly, which means incurvature of the fifth digit. Here we have a fixed flexion contracture of the digit, and this is called camptodactyly. Where the digits are short, this is called brachydactyly. Where they're excessively long, that's called arachnodactyly. And where we have supernumerary digits, that's called polydactyly. And it's most common for polydactyly to be by the fifth digit, so post-axial. But so that's very common, but pre-axial polydactyly would be a significant dysmorphic feature. And then we may have overlapping of the digits as seen in certain syndromes like trisomy 13 and 18. Looking at the hands, as we may have a single uninterrupted mid-palmar transverse crease as seen in Down syndrome, and an abnormal whorl pattern that is also seen in Down syndrome. Not to spend a lot of time on this, but this is called displaced distal axial tri-radiate angle. So if we look at your own hands when you have the time, you will note that at the base of the index finger, you have whorls in 3 directions. And so if you took a point at the center of those 3 whorls, same thing at the base of the 5th digit, and same thing proximally on the palm, then this angle is called the distal tri-radiate angle. In Down syndrome, this point is displaced distally, and so it makes the angle more obtuse, and that is a finding of the hands, of the markings of the hands in Down syndrome. And those markings of the hands, we talk about the dermatoglyphics. Okay, so in Down syndrome, there are abnormal dermatoglyphics. The feet, we may have the rocker bottom feet with a prominent talus and flat foot, and this is seen in trisomy 18 and 13, or a wide first interdigital space called the sandal gap, which is seen in Down syndrome. So what we've done effectively is to examine the child for dysmorphic features from the head to toe, and at the end you ask yourself, you put all the findings together to say, can you recognize a syndrome? So you certainly should be able to recognize trisomy 21, and these are some of the features: a flat occiput, brachycephaly, excessive skin at the neck, so excessive nuchal skin folds, epicanthal folds, upslanting palpebral fissures, spots within the iris, so these are called brush field spots, strabismus, cataracts, midfacial hypoplasia, a large or protruding tongue, small dysplastic ears, narrow ear canals, that single uninterrupted transverse midpalmar crease, short broad hands, short digits, brachydactyly, wide space between the first and second toes, sandal gap, obesity, and generalized hypotonia. In trisomy 18, or Edwards syndrome, this is characterized by clenched hands with overlapping digits. We see the rocker bottom feet, the narrow pelvis, and crossed lower limbs. These kids have low birth weight, microcephaly, sort of prominent nose, small jaw, micrognathia, and unusually shaped chest. They may have pectus carinatum and a short sternum. In trisomy 13, looks quite similar in some respects because they have the overlapping of the fingers. They may have the rocker bottom feet, but trisomy 13 is characterized by clefts, so cleft of the lip or palate, and scalp defects. They may also have the eyes close set and hernias, as well as the skeletal abnormalities, the small head microcephaly, micrognathia, and undescended testes. We spoke about Russell-Silva syndrome. So we spoke about the large head for body size, the wide forehead with a small triangular shaped face, the clinodactyly, that they have short stature, and they have caffeole macules. Marfan syndrome is characterized by tall stature, long digits, arachnodactyly, scoliosis, and an abnormal shaped head. Will come to dolichocephaly. They also have high arched palate and hyperextensible joints with their positive wrist sign and thumb sign. So the wrist sign means that they can wrap their fingers around the wrist such that the thumb and the index finger overlap. So that's a positive wrist sign. And the thumb sign, they can easily adduct their thumb well across the palm. And when they've closed the fist, the phalanx of the thumb is overlapping. So that's a positive thumb sign. They also have an increased arm span to height ratio greater than 1.05. They have pectus excavatum, and because they may have lens subluxations or dislocations, they could have cataracts. Prader-Willi syndrome, as I told you about, these children have infantile hypotonia, the almond-shaped eyes, small hands and feet, and they're obese. So this is a young man from our clinic with Prader-Willi syndrome, and you can see that his habitus is very similar to this one in the picture below. We remember Prader-Willi syndrome by remembering 5 H's. So they're hypotonic as infants, they eat excessively, hyperphagia, they have low IQ, so hypomentia, they have short stature, hypometria, and they have underdeveloped genitalia, so hypogonadism. Turner syndrome, which you guys recognize very easily, short stature, webbed neck, wide space nipples, sheet-like chest, delayed puberty, and what this child is showing, which you didn't see in the other picture, is a wide carrying angle at the elbows. Noonan syndrome, these children have low-set posteriorly rotated ears, blue irides, wide-spaced eyes, down slanting of the palpebral fissures, some droopiness of the upper eyelids. They also have a broad webbed neck, unusual chest shape, wide set nipples, short stature, and cryptorchidism in males. We spoke about fetal alcohol syndrome, in which they have the epicanthal folds, the broad nasal bridge, the anteverted nares, the smooth philtrum, the thin upper lip, small mid-face, and then all of these developmental issues. And then the last syndrome I want to share with you, which I hope you will read about, is Fragile X syndrome. So it's the commonest genetic cause of intellectual disability in males. These children have a prominent forehead, long, narrow face, prominent jaw, large outturned ears, high arch palate, dental crowding or malocclusion, strabismus, and when they've gone through puberty, they develop enlarged testes, so macroorchidism. These are some references, and that concludes this lecture. I can take any questions you need now. Are there any questions? Okay, so we're going to go on to the other lecture, which is examination of the head in children. All right, so we need to be able to examine the head accurately in order to arrive at an appropriate assessment and reasonable differential diagnosis. Now, we said the principle of examination for dysmorphisms was a head-to-toe approach. For examination of the head, we stick to inspection, palpation, percussion, and auscultation. So what do we inspect the head for? We inspect for head size. The head may be unusually small, obviously, and that's microcephaly, or unusually large, obviously, macrocephaly, or may seem to be normal in size, normocephaly. We inspect for the head shape, any apparent lumps, scars, and distended scalp veins. In terms of head shape, the head shape may be normal or abnormal. and we will go through some of these abnormal head shapes. Abnormal head shapes may indicate that there's deformity, either from persistent, prolonged fixed positioning, so you're always lying on one side of the head, or premature sutural fusion, and the term given to that is craniosynostosis. So just to review some of the cranial sutures. I'm not sure if you're able to see my pointer, but looking at the head from above, this is the nose. So in the forehead, between both frontal bones, there is the metopic suture. Then we have the anterior fontanelle, which is bounded anteriorly by the metopic suture, laterally by the coronal sutures, and posteriorly by the sagittal suture. And then we have our posterior fontanelle, which is triangular in shape, bounded anteriorly by the sagittal suture, and on both sides posteriorly by the lambdoid sutures. So we met this in the previous lecture. So if we have premature fusion of a suture, then there is restricted head growth perpendicular to that suture. So where we have premature fusion of the metopic suture, there's restricted head growth perpendicular to the metopic suture. So you end up with a triangular shaped forehead, and this is called Trigonocephaly. If you have premature fusion of the sagittal suture, the head continues to grow, but is restricted in growth perpendicular to the sagittal suture. And so you end up with a head that's elongated in the AP direction. And the two terms for this head shape is scaphocephaly or dolichocephaly. And as mentioned before, some children with Marfan syndrome have this unusual head shape. Then we have where all the sutures have fused too early. And so the only expansion is through the anterior fontanelle until it fuses. And so this leads you with a tower-shaped skull called Turicephaly. Alternate terms are acrocephaly or oxycephaly. And where there's premature fusion of both coronal sutures, then there's restricted head growth in the AP direction, ended up with a flattened occiput, and that's called brachycephaly, and that's a characteristic head shape in trisomy 21. Now, plagiocephaly speaks to an asymmetric head shape, and it may be due to two main reasons: craniosynostosis or persistent prolonged fixed positioning. So the first example here is plagiocephaly, this asymmetric head shape due to persistent prolonged fixed positioning. And this may happen when a baby has come out of an environment that is crowded in the womb. So if you have like multiple gestations, or you have severe oligohydramnios, or you have an abnormally shaped uterus, then that might restrict the fetus's movement and result in plagiocephaly. Or if after birth they're just lying in one position for a long time, that may result in plagiocephaly. So this first example is not due to craniosynostosis. And we recognize this by examining the head from above. So as we examine the head from above, we're seeing here clearly that there is prominence of the right frontal pole and the opposite or left occipital pole, and the ear is displaced anteriorly on the side on which there is frontal bossing. And so this tells you that this is due to persistent, prolonged fixed positioning. On the other hand, you may end up with an asymmetric head shape because one suture, either the coronal or lambdoid suture, has fused too early. Remember that when there's premature fusion of the suture, there is restricted growth perpendicular to the suture. So here we have the lambdoid suture, which has fused too early. There's therefore restricted growth in the AP direction on the right side, but continued growth in the AP direction on the left. So you have frontal bossing and parietal or occipital bossing on the same side in that situation, and there's no significant displacement of the hairs. You may also palpate that there's ridging over the suture that has fused too early. These should be distinguished from one another because the plagiocephaly, due to prolonged fixed positioning, would likely resolve with time, whereas that due to craniosynostosis won't. And this picture in the bottom of a child with a little helmet on is an example of one of the methods used to treat positional plagiocephaly, where a helmet is worn, is adjusted as a child grows, and sort of induces pressure points along the head to sort of mold the head into a more or less round or oval shape. Are there any questions so far?
Doc, can children end up with microcephaly if those aren't adjusted correctly?
What isn't adjusted? The helmet?
Yes, Doc.
I don't think so. Yeah, I don't think so. No, I don't think so. All right, so just of interest, I had hoped I would have had some pictures, but we actually had I'm going to see this patient later today, but we actually had a baby who was born earlier this year with Sagittal Craniosynostosis. So he had a head shape like this. He's now about 4 months old. So he actually, these cases of craniosynostosis are not self-limiting. So depending on how severe it is, they should be referred for, well, all craniosynostosis should be referred to the neurosurgeons for an opinion. And what they will do, depending on the parents' wishes, is to try to correct it by removing bones around the suture that has fused early to allow it to open up. So we had a little boy in the nursery. He's 4 months old now, and he was born with this sagittal craniosynostosis resulting in scaphocephaly. It was proven by doing skull x-rays, which showed that the sutures had fused early. He went to the States and he had surgery to remove this suture and the bones around it, and this was done through some endoscopic procedure. So not a big scar, just a little scar anteriorly and posteriorly. Right after the sutures removed, you could see that his head shape returned to pretty much normal. And then in his follow-up, he's actually wearing a helmet for I think about 9 months to maintain or to induce a normal head shape. Now, so those are when we have isolated cases of craniosynostosis, so one suture fused early.
Excuse me,
but
no?
when we have, yeah.
Sorry. What would cause the sutures to close early? And
like a genetic disorder.
Oh, okay. And after opening the suture in the case of that baby, it will close again on its own?
Right, gradually over time, as all the sutures would. So what they do is that they just remove a strip of bone parallel to the suture, allow it to open up, and then it will gradually close over time. So it's like you just created, open back up the suture, and then that suture will fuse over time. All right, so all of those abnormal head shapes we discussed were more or less speaking about the involvement of one set of sutures, right? But there are some syndromes where you have multiple sutures which have fused early, and one of these is Cruison Syndrome. With Crouzon Syndrome, you have multiple sutures which have fused early. When that happens, you can imagine that the head cannot grow to accommodate the growth in the brain, and so you can end up with some raised intracranial pressure. With Crouzon syndrome, there are other craniofacial abnormalities such as hypertelorism. They have shallow orbits, so they have exophthalmos, strabismus. They have a beak-shaped nose, short upper lip, and hypoplastic maxilla. This baby has a trach for some reason. So when you have these craniosynostosis syndromes, again, they should refer to neurosurgery because it's not going to get better with time. And what they will do is, usually it's for the craniosynostosis, is simple suturectomy, which in centers which do it often now is a simple procedure. But with like a syndrome like this, it's not just the sutures that have to be addressed, but there needs to be some maxillofacial involvement to sort of correct the abnormalities in the facial structures. So that becomes quite involved. Another craniosynostosis syndrome you should know about is Apert syndrome. And as you can see, there are multiple craniofacial abnormalities, prominent forehead, wide space, wide nasal bridge, down-slanted palpebral fissures, anteverted nostrils, short philtrum. Multiple sutures have fused early, but this is associated also with severe syndactyly of the hands and feet. So again, this needs referrals to orthopedics and plastics, neurosurgery, and maxillofacial surgery. In terms of head lumps in neonates, so we've gone through abnormal head shapes and discussed that this may be due to craniosynostosis or due to prolonged fixed positioning. So now we're going to go on to head lumps in neonates. Are there any questions? Any other questions so far? All right, there are two main head lumps that are seen in neonates, and that's the caput succedaneum, which just means scalp edema, or the cephalhematoma, which is due to hemorrhage below the periosteum of one bone. And they're distinguished. Usually both occur with vaginal deliveries, but the caput succedaneum, the swelling crosses sutural lines because it's actually scalp swelling, whereas with the cephalhematoma, the swelling is limited to the skull bone with which it's associated and therefore does not cross sutural lines. They both will resolve spontaneously. However, because the cephalhematoma, there's actually blood beneath the periosteum. This blood can be a source of excess bilirubin, so these children can have hyperbilirubinemia. And then just to alert the parents that although this will gradually resolve, sometimes the lump hardens and before it remodels and the head, resumes a normal head shape. So all of that was inspection, and now we're at palpation. By palpation, we want to measure the head circumference. Just remember that another term for head circumference is occipitofrontal circumference, which means that the tape measure must be passed along the most prominent aspect of the head anteriorly, frontally, and occipitally. And frontally happens to be about a centimeter or two above the eyebrows. This is a poster that was in wide circulation in about 2016 when we had our Zika outbreak. And here we can see the microcephaly and extreme microcephaly. We also palpate the fontanelles for their size, for their tension. Is it flat, sunken, bulging, or tense? And whether or not there's a middle fontanelle. So middle fontanelle is a dysmorphic feature. The fontanelle may be sunken in the child who's dehydrated, but may be bulging and tense when there's raised intracranial pressure, such as meningitis, hydrocephalus, or even an intraventricular hemorrhage. We also palpate the sutures, which should have a diameter less than or equal to 5 millimeters. So if it exceeds 5 millimeters, the sutures are said to be splayed. And again, this might be in keeping with hydrocephalus. Or the sutures may be overlapping, particularly in the first day or two of life, and this is due to molding. But the sutures can be ridged where they're closed prematurely, such as in craniosynostosis. We also palpate the skull bones to see if they're the normal consistency. Where we have soft skull bones, this might indicate craniotabes, which is a feature of osteogenesis imperfecta. And we also palpate any scars that may exist, particularly where there's hydrocephalus with an associated ventricular peritoneal shunt. Then we percuss and auscultate the skull. We percuss the skull by using our stethoscope and putting the diaphragm on one pole of the skull while tapping on the opposite pole, and we should have a resonant percussion note. When that percussion note is hyperresonant, that is said to indicate a cracked pot or McEwen sign, which is a feature of hydrocephalus or hydranencephaly, or a large subdural effusion. We also auscultate for bruits over the closed eyes, the vertex, the temporal and occipital areas. And if we hear bruits, this may be normal in hyperdynamic states, but may also indicate the presence of an AV malformation. And then lastly, we transilluminate the skull. This should be done in a dark room, and a light source is applied to the infant's skull. So here's a light source. This is without. Here's a light source, and you can see the excessive transillumination exceeding 15 millimeters around the light source. And again, this is seen with hydrocephalus, hydranencephaly, large subdural effusions, or intracranial cysts. Any questions so far? Do you understand how to do the McEwen sign? Hello? Okay. All right, so I'm going to take that to mean it's clear to everyone. Okay. If you give me a minute, just give me a minute and I'll reach for my stethoscope and show you the McEwen sign. Okay. So I wouldn't be doing this on myself, but let's see. So if it were somebody else, I'd have the stethoscope on. You'd put the diaphragm on one pole of the head. You percuss on the opposite pole, and you hear that resonant note. So you need to be doing this to appreciate what normal resonance is. And when the resonance is increased, then you appreciate the McEwen sign. Again, for the children, sorry, not children, the students at University Hospital, we do have a little baby on ward 14 who has hydrocephalus. And so, if you go one at a time, you should be able to examine and appreciate the McEwen sign in him. Any other questions? Okay, so just to know some signs of hydrocephalus. These include macrocephaly, a large head circumference, the presence of distended scalp veins. Before surgical intervention, you may have bulging fontanelles and splayed sutures. After shunt surgery, you may have a scar in the parietal region or a palpable shunt. We may have the positive McEwen sign, positive transillumination, and some eye signs, a setting sun sign, as well as if you have a child with hydrocephalus, you should always examine the spine for the presence of a spina bifida. A spina bifida occulta is, myelomeningocele, 90% of them are associated with hydrocephalus. Other aspects of the examination that may be relevant to the examination of the head include looking for dysmorphisms, the spine, as we said, for spina bifida occulta, and the eyes looking for the setting sun sign, as well as for cataracts in the patient with microcephaly, which might indicate something like torch infections. So, Cabrino, that's this picture on the left, can you just point out the unusual features for me?
Okay, so for this patient, I can appreciate a large head. The child appears to have some macrocephaly. The eyes seem a bit wide set, so I would say that there is a bit of hypertelorism. The forehead appears large, and then it tapers down to a narrow chin. Yeah, those are the features that I can appreciate.
Okay, anybody else wants to say anything more?
There's a prominent vein, I believe.
Right, there's this distended scalp vein. Anything else?
Doc, would you say that this is the setting sun sign?
Absolutely, right. So be careful how we talk about eyes that are wide space, because remember that we have to do particular measurements of the interocular distance. And many times you have a wide nasal bridge, but the eyes are not necessarily wide spaced. All right, so they're not the same thing. But
okay.
are you hearing me?
Yes, doc.
Okay, I'm very sorry about that. Just had a power cut. But yeah, so we just made the comments about the examination as relates to hydrocephalus, and you may not be anymore seeing my slides. Are you seeing the slides anymore?
Yes, we're still seeing this slide, doc.
Okay, so the picture on the right, now you can see that in that picture that there are white pupillary opacities, right? And so the opacities are confined to the pupils. And so those are lens opacities or cataracts. And we'd have to think about a torch infection in that child. So are you seeing the last slide that says, finally, we come to an assessment of the problem?
Yes, doc.
Great. Okay, so we really want to look at causes of microcephaly, and you should be able to generate a list for causes of congenital microcephaly. Remember that if you have congenital microcephaly, then the insult likely occurred in the first trimester, early second trimester. You're looking at your genetic problems and your teratogenic exposures. Acquired microcephaly usually means that either there is a significant insult to the child's brain early, such as with hypoxic ischemic encephalopathy, severe meningitis, or so on, or also due to premature fusion of sutures. For macrocephaly, a way to think about it is that the enlargement of the skull, the cranium, or any of its contents, so CSF, blood, or brain itself, could cause macrocephaly. And so you want to fill in some blanks there. So for skull enlargement, you want to think like of some of the skeletal dysplasias, such as achondroplasia, where you have macrocephaly due to associated with that skeletal dysplasia. Increased CSF volume, then you can talk about the hydrocephalus, hydranencephaly, and so on. Increased blood volume, you could speak about the vascular tumors or intracranial hemorrhage. And then if the brain is enlarged, whether or not this is just due to an enlarged brain, which might be due to an abnormality of brain formation, cerebral dysgenesis, or a brain tumor, and so on. So you can fill in the blanks. And then finally, I would encourage you to generate a differential list for the child who has hydrocephalus. So is this due to, you may want to say, is it obstructive or non-obstructive, and fill in the blanks. Thank you. Are there any questions?
No, doc.
Doc, is it possible for you to
Can you hear us, Doc? Could you stop the recording, please?